So I think most people are familiar with Dr. Linda Cocchiarella, and she's been a QME for a long time. She's been an author of the guides and author of, responsible for writing and creating a lot of the apportionment and causation that we, utilize every day. So, Shaylee, come on up. Want everybody to know I'm Susan Postnikoff. For anybody who doesn't know, this is Shaylee Cicerelli. And Shaylee and I are the sales team, and want to make sure everyone feels really welcome here. We're so glad everybody was able to make the meeting, and glad to see you. So Dr. Linda Cocchiarella, author of the AMA Guides, 5th edition, I believe. And are you working on a 7th edition or something?
Well, I'm not, but I believe the AMA is.
Okay. So, author of the guides currently being utilized by everyone in this room. So glad to have Dr. Cocchiarella speaking for us the second time in a row at our annual meeting. And she's going to speak to us on COVID-19 and workers' compensation. Thank you so much, Dr. Cocchiarella.
Thank you. Is everyone comfortable if I take my mask off? Susan did the whole thing, but I just want to make sure because obviously you don't want to put anybody in this here. So thank you very much, Susan.
I'm going to mic you up.
Okay.
You don't have to stand up straight.
Okay. Okay, great. So, I'm sure many of you that are here as well consider yourselves among the fortunate to be here. I mean, we're very fortunate to be here. Such a beautiful setting, fabulous group. Thank you. I'm very, very honored and very thankful. What I'd like to do today is talk a bit about COVID, post-COVID conditions, and also to really have us discuss some of the challenges that we're facing in terms of seeing patients currently or claimants coming in with cases of COVID, post-COVID, and post-COVID syndrome. I'd like to just get a show of hands. How many individuals here have been asked to evaluate individuals that have had COVID for post-COVID conditions? So maybe about a third or so of the group. For those of you that haven't, I think you will start to see more of those claimants coming in. And what I'd like to do today is essentially go over some of the key points to keep in mind and that we can also discuss regarding whether COVID is work-related. Obviously, it's a challenge at times to make that determination. Look at some of the common symptoms that individuals have that have had COVID and that have what's called post-acute COVID or long COVID. There's been a variety of terms applied to this. We're going to be looking at who's at risk for increased symptoms after they've had a COVID infection. We'll be discussing a bit about apportionment and also how you evaluate these individuals, which is really challenging from a medical perspective, a workers' comp perspective, and how essentially you may look at approaching these in terms of an AMA Guides rating. We're informal here, so please feel free to either, jump in, ask a question, or we can take questions at the end, whatever you prefer. So long COVID has been challenging for many reasons. Certainly, as we learn more and more about COVID and the sequelae, we are able to find some distinctions between that as well as other syndromes. So we know that, for example, individuals that have been in the intensive care unit have a post-intensive care syndrome, which can include memory changes, deconditioning, etc. So one of the things we need to identify as well, for people that have been quite sick with COVID, are we really talking about post-intensive care syndrome, or are we talking about a unique set of symptomatology that is really beginning to come into play to be defined as long COVID? When we're asked as evaluators to assess whether someone has had COVID, some of the things that we'll obviously be looking at first is, have they had a positive COVID test? Whether it's been a a nuclear amplification test, such as a PCR test? Did they have symptoms? So obviously if they had a positive test, did they have symptoms at the time when they were technically prior to work, around the time of their work, essentially? Did they have symptoms consistent with COVID, fever, respiratory complaints, changes in smell or taste, muscle aches, diarrhea? Those are the most common symptoms. But what if their PCR test was negative? So there have been some individuals that basically have had a PCR test. So what typically happens that has been negative. So in those scenarios, it's recommended they get retested again 24 to 48 hours later. If it looks like they had COVID, then you can look for IgG serology 3 to 4 weeks later, or you can look for basically total antibody testing.
This might not fly if they are vaccinated.
Well, obviously the antibody test will not, correct. The only thing you could do is, in terms of the IgG serology, but yes, that's a good point. If they're vaccinated, you can't use the response from antibodies. If their tests are still negative, and then there's been some question raised as to whether or not they have COVID, then, there are certainly characteristic laboratory findings that have been identified pertaining to COVID, whether it's lymphopenia, elevated aminotransferase levels, increased LDH. The inflammatory markers have typically been elevated, at least one of them, ferritin, C-reactive protein, sed rate. Also, if they've had COVID pneumonia or respiratory complaints, they may have some of the classic imaging findings. And again, those can resolve, but if any of these were present, in some circumstances, if the test has continued to be negative, these other criteria are being used to basically give a diagnosis of COVID. In terms of whether or not it's considered to be work-related, AOE, COE, in terms of workers' compensation, there's been a variety of laws that have been put forth regarding presumption. And I've just listed some of the criteria here. You can essentially look up these particular guidelines. But basically, COVID has been considered to be presumptively work-related for workers who tested positive or were diagnosed with COVID-19 within 14 days after performing services at their place of employment. And that pertains to first responders and healthcare workers, but it can also pertain to other workers. For example, essential workers. They need to test positive after what's been defined as, quote, an outbreak at their workplace. And there's a variety of criteria that have been set up to identify whether or not there's actually an outbreak at their workplace. So you're going to be getting a copy of the slides. Susan will be getting a copy of everything, right? So you don't have to worry about, basically, writing any of this down or taking any pictures. So you're going to get all of that. But the most important thing, I think, is that the medical evaluator needs to defer to the trier of facts to determine if there has been a presumption triggered, or if they're basically saying that this is, being rebutted. So again, this gets into some pretty interesting areas in the case of rebutting whether or not something is related to work. So I'd like to just bring up a few points for discussion now. Let's look at a case I had of basically a hospital worker who was a ward clerk. So she doesn't have a lot of contact directly with patients because they actually come in front of her desk area. But she was in the area where someone was essentially brought in who was COVID positive after they were admitted to the med-surg floor. So the person passed by her office on admission. The timeline of when this actually happened was unclear in reference to when she had COVID. Initially, she reported no family members had COVID. Then there was some question about really whether the family had COVID prior to her diagnosis. She indicated, which has been the case I'm sure many of you have experienced, either personally or through histories, that there was not a lot of personal protective gear given to her. She was given a surgical mask only, no N95, because they were in short supply. And I think most importantly, other employees in the workplace had COVID. And she would be associating with them, for example, in the workroom, in the work area, in the lunchroom. So the sequence of that potential exposure was unknown. But there was a common lunchroom, and obviously then staff were without masks. You know, whether other staff had COVID, she was familiar with, yes, there were some other staff that had COVID, but it wasn't that she was ever told directly, you've been exposed to someone who has had COVID, you know, you need to basically go into isolation or get tested. She ended up becoming symptomatic. So I guess I'm going to put this out to the group and see, what are your thoughts in a situation like this, whether someone basically had a COVID-related exposure and if this would be work-related, assuming the time frame fit. Any thoughts, any comments?
I'm just curious, did the insurance company dispute this claim?
It seems like they were raising that, yes. It seems like they were questioning the rebuttal, I mean that they were basically rebutting presumption under the likelihood that, well, not in the likelihood, under the recognition that apparently some of her family members also had COVID, and it was really unclear whether they had COVID before her or afterwards. So, you know, in a case like this, I mean, I actually accepted this as industrial. I thought, given the degree of exposure that she had, you know, whether her family members did get COVID independently. But again, I think this raises some interesting questions for us to consider as evaluators. You know, when do you actually know whether or not someone had COVID in their workplace or whether they contracted it from a family member? But I think the bar to rebut presumption is actually quite high. And I think, you know, it's the employer's responsibility to do that. So I think in most cases, at least the way I'm approaching these, you know, certainly in a high-risk environment, I think the likelihood is that the presumption is accurate. So in terms of post-COVID conditions, it really is a consolidation of different names and different symptoms and different organ parts have basically been involved. So, you know, COVID's been referred to as post-acute sequelae of SARS-CoV-2 or PASC. Also COVID syndrome, long COVID, long haulers. The nomenclature for this phenomenon is evolving, and so there isn't one term that basically most of the investigators are using. The definition has also been evolving in terms of the symptomatology, how long it has to be present for. So essentially now CDC is recommending this be applied to individuals that have symptoms 3 months from the onset. It includes people who've either had initial mild infection, asymptomatic infections, or if they've had severe infections. And as you're probably aware, post-COVID's been associated with a spectrum of physical, social, psychological consequences. The incidence rates for post-COVID conditions vary. Some studies quote it as being 10%, others quote it as being up to 90%. I think the variation is because they look at how many symptoms is someone actually reporting. So technically, if someone has one symptom of continuing shortness of breath, then some studies will include them basically as post-COVID. It also depends on the follow-up. You know, we're having obviously longer follow-ups, but many of the studies are referring to follow-up being basically 60 days, some are 90 days. So, you know, we're getting more and more data as this evolves. There are multiple phenotypes pertaining to COVID, most likely. So there's the post-ICU syndrome that we discussed previously that's well characterized. And again, long COVID seems to be distinct from that with persistent symptoms. And again, you do not need to have the serious in terms of hospitalization, infection before that in order to continue to have symptoms. So in terms of some of the most common symptoms that individuals will present with quote, persistent COVID-19, among the most common are fatigue, shortness of breath, chest discomfort, cough, problems in terms of smell or taste. There are other physical symptoms being reported that are less common, but you still see them widely, whether it's joint pain, headaches. Some people are complaining of Sicca syndrome, rhinitis, problems with taste, poor appetite, dizziness, muscle aches, difficulty sleeping, hair loss, sweating, diarrhea. If you've seen some of these patients for evaluation, I can tell you that this is the consolidation of symptoms that I've been seeing. And it's interesting because I actually worked for a while after 9/11. I was a faculty member at Stony Brook University, and we had a clinic there for post-9/11 World Trade Syndrome, and it was in the very early stages of post-9/11. And we had a similar constellation, not of these symptoms, but a particular subgroup. For example, there was the reflux, there was some of the psychological issues, there was the shortness of breath and the RADS, and that was a constellation that seemed to be the case with individuals post 9/11. And we're seeing with COVID their own subgroup of residual symptoms. So I think from a disability standpoint, this is huge.
On the anosmia, it mentions 1 month, rarely longer. You're seeing a patient months after they've made their claim, and they still have the anosmia, but it could be a permanent residual, or it could be still a continuing residual last for months. How do you figure PD on that kind of a case?
Right, so that's a great question. So essentially, how do you determine, permanent disability of an individual who has ongoing symptoms of anosmia? What I'm actually doing, and I'm interested to hear what some of the other evaluators here are doing as well, but I'm actually trying to see whether they've really had all of the testing that they need to evaluate some of these conditions. So anosmia, you can basically do like a Snellen test in your office. You can send them to ENT. I like to basically see if we can extend it to, a year, certainly, and if they are going, if it's been more than a year and they have basically the persistent effects of decreased in their smell, then I will rate them, and I will rate them at, basically MMI and give them a PD. Anyone have any other comments on that? So who's at risk for long COVID? Well, again, this is another area of evolving information and recognition. Certainly individuals that have pre-existing conditions, diabetes, asthma, hypertension, individuals that are older. I'm not saying, seeing over 50 these days, basically, you're at higher risk for long COVID. If you're overweight, women seem to be at higher risk. And if patients had 5 or more symptoms in their first week of COVID-19 infection, then they're also someone who you may consider to be at higher risk. So, I've seen patients that basically, if I ask them what their original symptomatology was at the time of COVID, that are now complaining of post-COVID symptoms, well, they're getting pretty close. They're pretty much at 5. They had shortness of breath, they had headaches, they had cough, they had fever, they had extreme fatigue, so it's pretty common that they'll meet that criteria. And then the question is, what about apportionment? So, this is an issue that we're grappling with. Do you believe there should be apportionment for someone who is at high risk for long COVID? Maybe they didn't have any of the pre-existing diagnoses, but maybe they were, for example, pre-diabetic. Do you want to consider that as, essentially an apportionment criteria that put them at risk for long COVID? I think as more and more data comes out pertaining to what the input is for these different conditions and how they affect long COVID, I think we'll be able to make an apportionment decision better over time. The pathophysiology of COVID is really something that we're learning more and more about, especially as new variants emerge. So it's believed that basically the post-COVID is really, it's a continuum of the acute disease. The virus enters through the ACE2 receptors, mainly in the respiratory tract, It goes through the bloodstream. It enters into diverse organs, which is why it has such comprehensive effects. So it affects the lungs, the livers, the kidneys, the blood vessels. There seems to be basically inflammation of the endothelium in the capillaries, which is why so many organs have been affected. There's a lot of evidence about the formation of microthrombi. There's been inflammation, an inflammation cascade, and all of this triggers that inflammation cascade and cytokine storm. It leads to a hypercoagulable state. And again, this is seen in some of the inflammatory markers, an elevated D-dimer. There's an aggressive thrombosis in some individuals. And unfortunately, individuals don't often get tested for antiphospholipid antibodies, but in some of those individuals that actually have that condition that may be undetected, they end up having worse sequelae in terms of COVID. So again, this particular condition affects a lot of different organ systems. And you can have symptoms arise later that you never had in the beginning. So some of the symptoms here, as you can see, brain fog from a neurologic standpoint is what many individuals post-COVID complain of. And that can, normally I say to them, well, when you say you feel like your brain is foggy, can you give me some specific examples? One person indicated they were at a restaurant and someone had told them something about their good friend's shower and their baby being born, and she didn't remember it at all. I like to hear specific examples. Are they talking about maybe attention deficit, that they're missing things at work because they don't seem to be paying attention to things? Also, other neurologic symptoms, is there a persistent loss of smell or taste? Certainly, some individuals have had encephalopathy and stroke during their hospitalizations, and again, all of those would be considered industrial for someone that had post-COVID, had it during their COVID, and even afterwards they'd be at increased risk for thrombosis. Pulmonary symptoms, cough, shortness of breath, we'll get into the evaluation of some of this, chest pain. Dermatologic conditions are also being described, whether it's an urticarial rash, an erythematous rash. Some people say the rash has not gone away. Psychiatric is very common. Depression, PTSD. I see a lot of patients with anxiety. If you've had COVID, you have lingering symptoms, especially as a lay person, even as a medical person. I can speak from personal experience. It was anxiety producing having COVID, especially very early on. From a cardiovascular standpoint, palpitations have been common. Myocarditis, pericarditis, heart failure has been described. Individuals basically have had myocardial infarctions. And then some of the general symptoms, fatigue, joint pains, peripheral neuropathy, peripheral limb ischemia, all of this has been described as occurring as a result of COVID. I want to acknowledge really the land-breaking work and contributions of organizations such as the Long COVID Alliance. If you actually go into any of the lay publications or online and search some of these groups, they are incredibly organized, diligent, and really trying to educate us and work with us to help identify what the symptoms are that they still have, how they should be evaluated, and how basically they should be managed. And this is an international project going on around the world. It's actually being cited now as an example of what's going to be the new way that essentially medical providers, healthcare providers are interacting with the public in terms of their condition. They have really extensive sites. Has anyone gone online and looked at some of these long hauler advocacy sites that are international, where there's chat rooms and things, but they have guidelines that they've developed, that I've listed here about what types of workup they are thinking should be done. And the reason I'm bringing this to your attention, if you're unfamiliar with it, is that we're seeing these claimants and these patients, and they are getting online. They are understandably looking at this. They have a lot of this symptomatology, and they're going to be coming into your office, or at least I've seen patients come in essentially to me and basically say, you know what, I feel I have cardiac symptoms. My stress test has been unremarkable. I want a cardiac MRI. And this information is, basically being put forth for the medical community to look at and say, you know what, should we get these tests? Should we order these tests? So I'll be going through some of that a little bit more in terms of what CDC and some of the other medical groups are recommending, because what we want to do here is essentially acknowledge their symptoms, evaluate them to see if they have objective findings in terms of their symptomatology, give them whatever diagnosis is appropriate, and come up with some sort of treatment plan or future medical care that we can recommend to them, and to let them know that this is evolving. We are learning more and more about this, and as time evolves, we will have more recommendations and testing and hopefully treatment to give them. But obviously we have to start where we are right now. So again, variety of studies here you can look at and review. For individuals that have dizziness, that may have changes in terms of their blood pressure, autonomic dysfunction has not been uncommon. Tilt table testing has been used for many individuals with these symptoms, and they've actually been found to have abnormalities. How long this will persist for is unclear. So there's a variety of groups that recommend different degrees of assessment. So I'm going to go through a little bit of that. So, for example, CDC basically says that most post-COVID conditions can be diagnosed and managed by primary care. But if you feel that an individual really has, multiple symptoms, multiple body systems, there are COVID care centers that are now found in many places that are providing multidisciplinary care, more so at academic centers, but also in a variety of other medical facilities. And one thing to recognize, I think, from our part also is that, you can get into this realm of excessive testing where you encourage disability, where individuals may have some minor changes that will resolve, or maybe they're deconditioned. And if you essentially, we don't want to encourage that. Essentially you want to encourage ability, return to work when it's safe, when it's appropriate. So just something to be aware of. Many of the medical groups are recognizing that certainly conservative approach is warranted in the first 4 to 12 weeks. Obviously we're seeing patients much later than that. But if the symptoms persist beyond 3 months, then essentially they need more extensive evaluations. What's interesting is that there seem to be some studies and certainly anecdotal reports of individuals improving in terms of their symptomatology after they got the vaccine. So whether that's because they mounted more of an antibody response or there was some changes in terms of inflammatory markers that were reduced afterwards. I'm not sure if anyone has heard that or experienced that, but there are some reports pertaining to that. So I've had individuals come in as well that have had COVID that have basically said, I don't want to get vaccinated, I've already had it. I think this is another good reason to possibly bring that to their attention. It's important for individuals that have had COVID and that have ongoing symptomatology to ensure that they do not have some of these other conditions that may not be COVID related, or that they may have some of these conditions that are COVID related. So for example, if you've got a diabetic who's continuing to have some atypical chest discomfort and that had COVID, well, maybe it was the progression of their underlying coronary artery disease, or maybe it was a COVID-related myocarditis or a COVID-related progressive thrombosis, but regardless, they need to be evaluated for that. In individuals, for example, with pulmonary conditions, did they have asthma previously? Do they now have reactive airway disease? And again, there's an extensive list here of different medical conditions to consider that may be explaining some of their symptoms. Someone with marked chronic fatigue, are they hypothyroid? Could it possibly be some of their symptoms related to their diabetes that may be uncontrolled? So again, looking at them in totality and their general health is really important during these assessments. It's important also to determine how we're going to do an efficient evaluation. And one of the ways to do that, I believe, is to use symptom inventories when they're appropriate. Right now, we don't really have much in the way of symptom inventories. There are some coming out that are specifically for COVID. And the reason is it takes time to actually validate those particular inventories. So we're using, or what clinicians are using, are inventories that have been established for medical conditions that we're familiar with, such as COPD. So I'm just going to go through a few of them here, some of which I've used in my practice. I'm not sure if any of you have used these in your practice, but you may want to become familiar with some of these. So there's the PROMISE initiative, which basically has questions pertaining to cognitive function, and that essentially is something that you would access online. There's a functional status scale post-COVID. It's called PCFS. I'll be going through some of these in a little more detail. The mini mental status exam, I haven't found that especially helpful for COVID unless it's significant in terms of their deficits. I actually have been using more the MOCA scale, the Montreal Cognitive Assessment Scale, and I find that's picking up some milder deficits in terms of cognitive function. COMPASS 13 for dysautonomia, and then for psychiatric conditions, looking at obviously depression, PHQ scale, GAD-7 scale for anxiety, PTSD. So I'm starting to actually use more of these screening inventories. In terms of functional assessment, excuse me, can I just get some water? Yes. Thanks a lot. In terms of functional assessment, here's an example of the post-COVID functional status. So essentially you're finding out how much assistance they need, and you're essentially giving them a grade here. If they say that they've had some duties at work, which they're no longer able to perform themselves, then they would be considered to have a moderate functional limitation. How do you actually use a scale like this? Well, if you're going to be evaluating someone for a typical AMA Guides rating, and there's a large range of where to put them in terms of, thanks so much, Susan. There's a big range in terms of where to put them in terms of their disability rating. This scale may help you in terms of saying, well, their overall condition is actually a little bit more severe. There's also a fatigue severity scale. Again, the type of fatigue that individuals report pertaining to COVID is not, just tired at the end of the day. It's really debilitating fatigue. Some people say it's overlap with chronic fatigue syndrome. There's the dyspnea scale, the MMRC scale, in which essentially you ask them to grade their degree of breathlessness. Do they get short of breath only when they're hurrying on the level or up a slight hill? Or can they not walk with someone at their own age? Again, this is a scale that's been used commonly for COPD, but it does provide some helpful information for individuals that are short of breath with COVID, and again, can help you identify where in that range they are, whether it's basically mild, moderate, or severe in terms of a particular AMA Guides class. In terms of their complications, neurologic, so there's a whole range of significant acute complications that can occur with COVID. Chronic complications that are commonly seen neurologically are listed here. Problems with smell, taste, cognition, memory, attention and concentration decline, changes in terms of their executive functioning. They used to be able to multitask. They can't do that anymore. Their attention, a lot of problems with attention deficit I've been seeing. So one of the scales that I've used essentially is the MOCA scale, and it's interesting because I have found deficits in individuals, and you can kind of see when they're actually doing the test that maybe there's a problem in terms of their actually keeping attention to looking at, where they're actually drawing a line, or sometimes you can get an idea as well whether or not how much of it might be related to anxiety. Neuropsychological testing is something that I have been referring individuals to if they have prolonged neurologic complaints that are cognitively related, and especially when there's complications with ongoing depression and anxiety. Neuropsychological testing has been helpful. Basically, there's been deficits identified in terms of executive functioning and working memory. And the continuous performance test for neuropsych testing has shown problems in terms of attention. So they've had some attention deficits problems. And here's the different domains. Again, these are just some of the scales, the PHQ scale for generalized anxiety. In terms of some of the other assessment tools, there are a variety of tests that you can do. Basically, the 10-minute walk test, 6-minute walk test, evaluating them in terms of balance. For individuals where I believe there may be some autonomic dysfunction, which you can identify in the exam, sometimes what I'll have them do, depending on their general level of activity, is basically take a short walk, measure what their blood pressure is, their pulse. If I see that there's a possibility of some autonomic dysfunction, and based on their symptomatology, I may send them for tilt table testing. In terms of laboratory studies, for cognitive complaints, neurologic complaints, you've got to run basic labs, checking their thyroid, looking for correctable causes for memory loss. Vitamin D level is I think very important, not only for prevention of COVID, but also in some of the other symptomatology. It's prevalent in our society, and I rarely see a person who is not vitamin D deficient. And I do find that individuals that have higher levels of vitamin D, 40 and above, seem to actually do better in terms of their symptomatology and probably are reducing their likelihood of COVID. When do you consider imaging? Well, most of the, and I say traditional medical societies, medical academic centers, they're basically saying consider it if the individual has moderate or severe COVID, if they're over 50, if they have medical comorbidities, if there seems to be an impact on their job or activities of daily living, if they have any focal neurologic signs. I think in our scenario, we probably do have to go on and get additional testing. And also neuropsych testing can be very helpful. Usually workup for seizures are not productive, but if someone has episodes of altered consciousness, you may want to get an EEG, send them to neurology. Certainly, if they've got symptoms of neuropathy, the EMG can be normal, but small fiber neuropathy can still be present. They may need actually a biopsy for that. And also, if there's any concern about autonomic dysfunction, you may need to send them for testing on that. So, again, an extensive testing has not been helpful in the majority of patients, but a focused workup is warranted. Really important to get orthostatics for individuals who come in with any dizziness, fatigue, cognitive impairment, malaise, and again, checking, to see if they're orthostatic. In terms of GUIDES rating, so we had a question earlier, a very good question about, identifying whether someone is at MMI. My particular approach is I essentially try to delay giving them a rating to make sure that they've had all the testing that they need to try to identify, what the underlying reason is for their symptomatology. I try to prioritize what their most disabling symptoms are in terms of the assessment. Many individuals that have had COVID are still deconditioned, as are our patients with chronic pain for a variety of reasons. And so I look at essentially, take a detailed exercise history. I try to gauge what the role is of depression, anxiety, home and work factors as contributing causes to that. And also try to parcel out what's subjective versus any objective findings. And then if they have been essentially with the symptoms for a year or more, I will end up rating them based on the particular body symptom. In terms of what the yield has been, you know, a CT of the chest, in some individuals, it's been shown to have some changes, but, you know, if their chest X-ray is normal and their oxygen saturation is normal, depending on whether they've had inflammatory markers that have been elevated, depending on the severity of their symptoms, sometimes I will be getting a CT of the chest. Does anyone here, have you been ordering these for your claimants? Anyone want to comment? Okay.
How often are you getting approval from the insurance company for these?
Well, if I'm not ordering it as a treating or evaluating doctor, I'm ordering it as a QME or an AME.
Oh, I see.
So yeah, so in those instances, yes, they'll do it. Yeah. Anyone else? So I imagine you've been having some difficulty getting approval for it a lot. Yeah. It's important to see if you can, because the chest X-ray is normal, their pulmonary function tests have been normal. Yeah, yeah, yeah. Their exercise stress test may show some changes. So I don't know, Mark, do you want to comment on any of that? I know Dr. Hyman's been doing a lot of work here in terms of COVID.
Well, just a couple quick things. One is, when we talk about stress tests, I really like to emphasize I prefer cardiopulmonary exercise testing. Lynn and I have talked about that. And in particular, I like it with imaging. So that would be echo to really try to get a more definitive fix on that. Because as you know, with exercise testing, if you do just a regular treadmill, your sensitivity and specificity is going to be around a coin flip. But if you start going up to additional imaging, you get about 80–90% sensitivity and specificity. And if you add metabolic testing with it, you're really getting a very high level answer as to somebody's condition. And on the pulmonary function testing, I'd like to also encourage everybody that it's not just flow spirometry of a little desktop model. I'm talking about full pulmonary function testing, which looks at diffusion capacity, and also, ideally, if you do bronchoalveolar challenge testing. Those will help, I think, sort that out.
I agree. Very, very good points there, Dr. Hyman. Thank you. We'll be going into some of that in more detail, and Dr. Hyman does a lot of some of the cardiopulmonary testing. So we can talk about that a little bit further from his experience. At this time, there's no laboratory test that can definitively distinguish post-COVID from other conditions. It needs to really be guided by your clinical findings. So essentially, additional testing is needed, as we discussed earlier, if the symptoms are persistent, 12 weeks or longer. Here's a list essentially of, you know, the tests that are commonly obtained on individuals post-COVID that are symptomatic more than 4 weeks out. So besides your basic chemistry, you'd be looking at some inflammatory markers like C-reactive protein, sed rate, ferritin, thyroid function, vitamins B12, vitamin D. If they've got different rheumatologic symptoms, you may want to essentially get tests for looking at rheumatologic problems such as ANA, rheumatoid factor, anti-CCP, CPK. Any concerns in the past about coagulation, again, look at their D-dimers or fibrinogen. If there's concerns about myocardial injury, look at troponin levels. So all of these, again, need to be ordered in the context of whether there are findings that support them in terms of their history and physical. So this was a case that I was asked to see of an individual who was 55, essentially has a job where he works nights in a hospital, and he's in a room with all of the different patient monitors, evaluating them for any alarms or any problems that have arose. And he had COVID in November of 2020, and he had cough. He was hospitalized with pneumonia. He had some ischemic changes at the time. He was hospitalized for a week. He underwent rehabilitation. He had lost his mother and his wife the prior year. Actually, he lost his mother that year, and he's lost his wife the year before. So he had underlying depression. He was morbidly obese, diabetic, hypertensive. In his job, he actually came to me. It was an interesting case in that, he said he didn't think necessarily he got COVID at work, but he didn't know how he got COVID because he kept himself pretty isolated. He was living with his mother at the time, and she didn't have COVID. And but then when I spoke to him further, because he worked at night, he worked in this room by himself. This is not him, by the way. And he went into the lunchroom where the nurses on the other staff were during his breaks, and he also went into the hospital cafeteria. In any case, I ended up saying that I thought his COVID was industrial, and he had these residual symptoms of fatigue, arthralgias, paresthesias. He also had a variety of neurologic and cognitive complaints, which were probably his most concerning, among those being problems with attention, and he was concerned that he wasn't going to be able to be as quick or as responsive in terms of evaluating all the different monitors that he had to look at while he was essentially doing his job. In terms of evaluating him, that's still in the works, but essentially there were some abnormalities in terms of a Snellen test. He was sent for ENT assessment. In terms of rating him, we'll discuss that kind of in conjunction, but one of the things I always keep in mind is, if someone has fatigue, you could rate them with the guides according to the section on treatment effects, where you can give up to a 3% rating for an individual if their treatment or if their condition has not really returned to their baseline health. Essentially, cardiac evaluation is underway in terms of a Holter, getting the Holter while he's at work and also at home. He is getting a cardiology assessment. Well, we already had a stress test on, which I think didn't really reveal anything. He was sent for neuropsych testing because he did actually have changes on his MOCA test. He had this complaint of some episodes of brain fog. His laboratory studies, other than a vitamin D deficiency, were unremarkable. And he's also being evaluated by psychiatry. In terms of the AMA guides, rating something like this, you got to look at body system by body system. So for someone who may have a worsening of their blood pressure or problems with blood pressure control, which is the case with him, I'm waiting for his autonomic testing to come back, but he could be evaluated basically in the section on hypertensive cardiovascular disease. In terms of smell deficits, again, the neurologic chapter has a lot of tables and sections which you can apply for rating individuals with neurologic dysfunction. So in this particular case, he's got some problems in terms of odor recognition. You can use essentially table 13.4, in which you can get a rating for olfactory nerve dysfunction. That rating is a maximum of up to 3%. You can evaluate an individual for partial loss of taste after you've tested that or documented that. And again, that rating can be 1 to 4%. In some instances, you may want to use an Alvarez-Guzman analysis for a partial loss, because with the taste rating, it actually requires you to have total loss of taste. So I would actually rate the person with a partial loss of taste. For individuals, again, that have autonomic dysfunction, you could evaluate them based on this particular table, looking at an episodic loss of consciousness or awareness, in which they may have a blood pressure decline. And in the neurology chapter, it's indicated that you assess the most severe central nervous system disorder. So if someone has a dementia rating, or a cognitive decline rating, or they have an autonomic dysfunction rating, which is centrally mediated, then you would rate them based on either, but not on both, according to a strict interpretation of the guides.
So how long after the COVID you saw him?
I saw him probably, 6 or 7 months afterwards. Yeah, so I'm waiting for, the evaluation.
And he's returned to work?
He is going back to work on a graduated basis, which is what I recommended also. You know, they're doing a graduated return to work to see how he responds. And that's the other thing too, you know, I think our obligation also is to, you know, inform employers, inform the different parties of interest that they need to be flexible, which I think more of them are being now to some extent in terms of working with these individuals that hopefully will get back to their employment. You know, the studies are showing that there's a significant number of people that had mild symptomatology. 1 in 5 patients not requiring supplemental oxygen during hospitalization had decreased lung function after 6 months. And I agree very much with what Dr. Hyman said. You need to have a full pulmonary function test. Standalone spirometry is insufficient. The degree of respiratory impairment, certainly in acute cases, can be quite extensive with interstitial changes, alveolar changes, fibroproliferative changes. Again, the array of changes we've seen in terms of COVID has been unprecedented. The role of cardiopulmonary exercise testing should not be understated. The only challenge that I've been finding is actually finding places that will do it because of problems in terms of potential exposure. They're not, they've a significant demand, but basically CPET is recommended to confirm or to diagnose changes of unexplained dyspnea, unexplained shortness of breath, and it can reveal problems in terms of the respiratory system, the cardiovascular or muscular symptoms, and can help to explain what the causes are for shortness of breath. It can be used for prognosis. It can also be helpful because it can help guide the individual, well, really a lot of this is deconditioning, and it can help them recognize that they need to start exercising more, they can exercise safely, they can get back to work, but that this is going to really require, you know, a significant rehabilitation component, and there are programs that you can send individuals to for that. Again, the cardiopulmonary exercise test can help distinguish these different criteria, whether it's cardiac, whether it's ventilatory, whether it's muscular related, and you can rate some of these findings based on the guides. Dr. Hyman, since you do a variety of these CPE tests, can you share with us some of your experience in terms of what you've seen or what some of the challenges may be in interpreting some of these?
Sure. Just real briefly, just a couple things. One is the key metric on cardiopulmonary exercise testing is, did somebody reach the anaerobic threshold? That's the key metric. Did somebody reach the anaerobic threshold? If you reach the anaerobic threshold, then you know when someone has hit the point that they've given you their full effort, and you know what their abilities are. And if they have not hit that number, then there's a question of whether or not they give you a full effort or whether or not they are truly deconditioned. But mind you, Dr. Cocchiarella is absolutely correct. This test is both diagnostic and therapeutic, because when you put somebody on treadmill and you show them what they're capable of doing, that can overcome a lot of fears that they have about their condition. And so this can be extremely helpful in that regard. Further, one thing I always like to point out whenever I'm doing this, sorry, just go a little more quickly.
Oh, please.
Is if you tell me that somebody is deconditioned, then what that raises for me is that somebody's not at maximum medical improvement. So I want you to keep that in mind. When somebody says, well, I'm weak, I'm tired, I'm worn out, or something like that, and therefore I can't go on, and you do this testing, and you see that they are what appears to be very deconditioned, then my response is that I'm not sure they're at maximum medical improvement. And I'm not sure that that's the time to rate them. And so that's the other point that I want to emphasize.
Great. And Mark, what's been your experience also with having them enter some type of rehabilitation program? Because I've seen kind of mixed things. I mean, obviously there's some very good ones there, and then I've had claimants that have said, oh, you know, they really didn't have me do very much, they had me walk a little bit, and
Yeah, I think there's obviously partners in that decision. One is the doctor, one is the program, and one is the patient, right? And so, not to get told I'm talking, but if you ever looked at the AMA Guide's companion book on workability, we have the concepts of risk, capacity, and tolerance. And so when you're looking at in that reference, use that framework when you're approaching these people. What is the risk to them of doing these things? What is their objective capacity? And then finally, what are they willing to tolerate? And that can help guide you as to how to interpret the program that they're in. But the advantage of doing the testing that Dr. Cocchiarella is emphasizing is that you are starting to get them in the mindset that they have abilities and resources that they might otherwise be hesitant to use.
now that's an excellent point.
Well, there's a
Thank you.
presumption that the patient is giving their full effort. There's a presumption that the person doing the testing is giving the instruction for that patient.
Right.
Full effort. We're just getting something back that has some subjective factors thrown in there. Is that correct?
Getting something back in terms
Well,
of,
there's some things in there that the patient is in control of if they're not giving their full effort.
you mean if they were getting the CPET?
If they're getting the CEPT and the testers maybe not giving the instruction or providing a very competent test
Yeah.
to show the individual's capacity.
Yeah, I mean, Mark, do you want to address it all? I mean, I think, for the CPET, hopefully you're getting that report back that is addressing what their effort is, but I assume that I imagine some reports are not quite as detailed in that as you'd like, yeah. So again, regarding the pulmonary function test, really important that, with the CPET, again, they found that in a significant number of patients, there was one study done looking at 41 patients post-COVID. They had normal pulmonary function tests, the CT scans, chest x-rays, echoes. Basically, they were all normal, but they complained of persistent shortness of breath more than 3 months after recovering from COVID. They were found, though, to have ventilatory abnormalities on CPET. They were hyperventilating, taking shallow breaths. Some of this breathing can contribute to underlying shortness of breath. Some of them had, more than half had a peak oxygen consumption below 80% predicted. All had a circulatory limitation to exercise. And others basically had different ventilatory abnormalities, dysfunctional breathing. So again, it's unclear yet whether or not some of the modifications, even some of the respiratory therapy where they can learn other breathing techniques can be helpful to them, but in some instances they may be. So again, depending on the parameters that are reached, you could use essentially this table from the AMA guides to assess them in terms of their VO2 max or their DCO, depending on what's found on the cardiopulmonary exercise test. If an individual was using an inhaler, and especially if you can get a methylcholine challenge test or some type of challenge test to see whether they actually do have reversible bronchospasm, then you can certainly rate them in the guides based on a respiratory impairment for asthma. In terms of some of the other symptoms we discussed, we already talked a little bit about the neurologic symptoms. And cognitive changes can be evaluated with the AMA guides. Again, I would not rate them unless I had a neuropsych assessment that really documented how much of this may be an actual deficit in terms of cognitive decline versus depression or anxiety. And again, our goal is really to try to optimize their quality of life and their function and get them back to work if we can. So I included here some of the recommendations from some leading medical centers in terms of how they assess individuals that have post-COVID, for those of you that may actually be treating these, and I think you may want to refer to these later, but they actually give a very nice scenario here as to what type of initial assessments to do, what order, ensuring that they've had appropriate physical therapy, occupational therapy, certainly anyone with breathing problems previously, or even subsequently, I would be reviewing, what their overall respiratory rate is like. I think the shallow breathing is not uncommon in some of the individuals that had residual shortness of breath. And know that obviously our database is continually changing hourly as we speak regarding COVID, variants, management, conditions, etc. So I hope this was a nice quick overview for you regarding some of the considerations pertaining to AOE, COE. We talked a little bit about post-COVID syndrome, what the risk factors are, a little bit about apportionment, and again, hopefully some of these references will give you some further information about how to approach this when you have claimants coming in with these conditions. I'd like to acknowledge basically CSIMS. They had some very nice presentations on long COVID. Some of them were done by Dr. Hyman. I wish we had been doing this together, but unfortunately that was my poor schedule planning, but Mark is very experienced in evaluating patients with COVID and doing a lot of the testing himself. CDC has extensive references, wonderful PowerPoints. There's a particular segment that I like to listen to called TWIV. It's on the East Coast. It's from Columbia. It's called This Week in Virology. They have panels of virologists from all over the world talk about COVID, and they also have some clinicians discuss some of their experiences in treating patients with COVID. I find that to be a really valuable podcast. I listed a variety of references here, some of which I've looked, many of which I've looked through. These are actually from the CDC. ACOM has put out, thank you Mark for giving me these slides. ACOM has put out these references here pertaining to COVID, and they've had panels essentially looking at this. And also, there's been some articles written in the AMA Guides newsletter. This was another publication about evaluating and rating COVID patients, how to help COVID patients reach MMI. Mark, how do we get a copy of that admirable review, or how do they get that?
Those two papers that I wrote, it's the state of Tennessee. It's an 8-state consortium, and those are available free and online.
Okay.
You go to the state of Tennessee, their Bureau of Workers' Compensation, and it's an 8-state consortium that they do peer-reviewed work on. So that's how you get those two. The Guides newsletter, I think you have to be a member.
Subscribe to it. I don't know if maybe Susan, we could talk with them about getting it for the group, that particular issue.
Okay.
That would be great if they may be willing to do that. And,
right, and then the ACOM, the national guideline from ACOM that we wrote is ACOM's materials are housed by MD Guidelines. MD Guidelines is part of the READ group. They're based out of Colorado. So you just go to MD Guidelines, and they have free front-facing the COVID guidelines. There are databases and the other things, that's the subscription stuff, but the actual guideline that we wrote for ACOM is available for free.
Thank you. Questions?
I would like your comment on an interesting case I did this week, rather. There are some things which kind of are puzzling. This 32-year-old lady had COVID in January, and which was acknowledged.
January this year, huh?
This year.
Mm-hmm.
And I was given this QME this week. She has all the symptoms which is written in the book still present. And she resigned from her job in October because she couldn't mentally concentrate or recall the work. And she had an interesting complaint of right arm pain since February. MRI, nerve conduction studies, all are normal. And the complicate the matter, she didn't want to come to my office, it was through the Zoom. How can I evaluate over the Zoom all the symptoms, and I couldn't explain the right arm, right shoulder pain. She refused physical therapy because it aggravated the pain. And in the video, I made her do certain things, and she was able to do it. So where to go from here?
Okay, so that's an interesting case, and maybe we can discuss that a bit as a group. So there are a few things that you brought up. So one of the things is, evaluating someone basically via, Zoom. Right. So, I mean, I think you mentioned, well, first of all, let's start with her history. So she said regarding the pain, what was the pain like? How did she describe the arm pain?
Yeah, arm pain, I asked her, she said it's on the scale of 1 to 10, 5 all the time, and 7 to 8 when she types or do housework. And Tylenol helps for a few hours.
So she's doing housework and she's typing. So she's obviously doing some activities.
She was doing it till she couldn't do it in October. She resigned from her job.
And what was her range of motion like?
Good, she could do on the video, she could do all the range of motion.
And so the quality of the pain that gets back to, so how I would approach this is, I would basically look at, what the history was in terms of the quality of the pain, see if I could define it any better. In terms of the studies that she's had, I don't know if she's had, you said she had a cervical MRI, did she have
had the arm and the shoulder, because it was more of a forearm pain. And now she's describing forearm tingling and numbness going into the hand.
Right. So, has she had an MRI of the brain?
No.
Yeah.
So I have suggested that.
Yeah. I mean, she's clearly not an MMI, so I guess how do you evaluate someone who doesn't want to come into the office and basically got to do the assessment with Zoom? Well, I think you do exactly what you did the best you can. You document as much detail as you can in the history, you document what you can in the physical exam, regarding her range of motion. You get the appropriate tests that you think are going to help lead you in terms of a diagnosis, whether that's the MRI, whether that's the brain, the cervical, you've done some of that. I don't know what her underlying history was. Does she possibly have, any other medical problems? I don't know what her medical records show.
History except hypertension, for which she was on one single medication.
Okay.
She was the manager of 3 clinics for a FQSC.
And she said that this arm pain developed as a result of
after COVID.
She
has anosmia, she has fast pace, she has shortness of breath, she has fatigue.
Right.
So she had brain fog,
right.
Loss of memory.
Right. So she's got a whole slew of neurologic problems. Plus she's got this upper extremity problem, which could be like a cumulative trauma and a myofascial pain syndrome. But you want to make sure she doesn't have any type of thrombotic event as a result of a COVID event.
They did the ultrasound before they sent it to me for the arm DVT or anything. That was all
fine. Okay. All right. So it sounds like, it sounds like you're doing, anyone want to raise any other questions or comments about that? Good, interesting case.
I'm a chiropractor, and I think that as a stress, you could definitely have some cervical problems. To send up for like a free treatment like chiropractor, also as far as the forearm, if that gets worse when she works, that sounds like trigger points to me. So maybe some stretch or some injections for it.
I told her that I can't give evaluation till she come to my office and let me examine her.
Yeah.
And I only sent her to neuropsych evaluation.
And did she go, but you said she declined the therapies that were offered.
She declined the physical therapy for the pain because she went once and it aggravated her pain according to her, and she stopped.
Yeah, maybe even, I don't know whether she would agree to any acupuncture. Acupuncture is highly variable depending on the practitioners, I'm sure you're aware, but if you can find someone that does Japanese acupuncture, it's a different type of acupuncture that is gentler and may have some longer lasting effects. Any other comments?
Did you feel like she was credible?
Did she feel like she was
Credible.
Yes, that was my question too. How do you rate in these, like fatigue is so subjective.
Right.
Shortness of breath is so subjective. And pain is all subjective.
Right, right. I mean, I try to do that by talking with them about their general life, you know, and seeing what's going on in their general life in terms of kids, grandkids, who are they living with, what are their general daily activities, to get an idea as to how functional is this person really.
Asked that.
Uh-huh.
She lives with 2 daughters, 16 and 18, and she says, my mother comes and helps me with the housework, and
Right.
my husband helps me with the housework.
Right. So does the husband work? What sort of job does he have? What sort of hour? I mean, I do get into the granular details as much as possible, but these are challenging cases, I agree. Did you?
Okay, I'm an orthopedic surgeon, so with deconditioning, general deconditioning, shoulders are the first joints to be painful and sore. And patient often can develop what we call frozen shoulder, unless maybe she has diabetes as well. So the shoulders are really the most sensitive joints from all other joints. When patient gets deconditioned, weak, he's losing less arms, and that's one of the reasons that he can develop bursitis and then.
But how can you explain the forearm pain?
Oh, that's anything in the shoulder can radiate down to the arm. People have tingles, numbness, and they will describe the symptoms of carpal tunnel when they actually have shoulder bursitis engagement. So that's
Even with normal MRI?
did she have normal MRI of the shoulder?
Yeah.
Sometimes, yes. I mean, sometimes you'll see.
Maybe she has
patient frozen
impingement. Did she
shoulder,
have any
that's almost
impingement
like
signs?
normal MRI.
And nerve conduction is negative?
No, but did she have any impingement signs?
No, not on the questioning.
No, not like when, you know,
Yeah, she did that.
and she didn't complain of
No,
any
she
increased
didn't.
pain with impingement. Okay.
And the nerves of the cervical spine tower the shoulder, so C6,
Right.
C7, C8. So really evaluating what the other chiropractor said, really some cervical adjustments could potentially really help the shoulder and anything going down the shoulder as well. I've seen that. And then when I see her live or have her push down on top of her head for cervical compression at home and see if she's being truthful, but does she have increased pain or not increased pain, positive sign of cervical compression. And then I would actually do a patient's cervical distraction and see if that alleviates some of their pain.
Also, you know, if someone's saying too that they've got a lot of forearm pain, I like to identify, you know, in terms of their computer work, what's their setup like at home. You know, obviously we've seen a lot of this people working at home now, but, you know, the home ergonomics for many people are absent. And I find it not uncommon that, you know, people are not supporting their forearms at all. You know, they're kind of leaving, and, you know, a lot of basically tension and increased pressure is, you know, extending from the shoulder down into the forearm.
So how do you differentiate for the memory loss and brain fog, actuality and subjective?
Right, so how do you actually look at some of the objective findings? Well, I always do a MoCA screen on these individuals, and if someone actually is, if the deficits are more significant, I go to a mini mental status. But if I find deficits on the MoCA or the mini mental status, I see as they're doing it, you know, the MoCA test. I mean, basically, are they having problems with attention, you know, with their memory? And I look at that in conjunction to the rest of my history and evaluation. So, you know, if they can't remember, you know, say, you know, several objects on the MoCA test, you know, whether it's church, Rose, whatever it is, but they can remember other things in their past, you know, it makes me question a little bit about how much of this is consistent with an actual memory loss or not. If I think there's something there, or if I think that depression and anxiety, or even some concern about, you know, things being exaggerated, then I will send them for neuropsych testing.
Yeah, I already did.
Yeah. Okay, well, thank you very much. I'm sure I went over here, but it's a really important topic, I think, for all of us.
Thank you so much. I believe better late than never. And so Dr. Cocchiarella is an MD with a Master of Sciences.
That's okay.
She is accomplished, very accomplished clinician, author, editor, and researcher. Her focus has been to integrate internal, occupational, and holistic medicine with evidence-based medicine to optimize individual and population health. She was the main medical editor of the AMA Guides 5th edition and author of several chapters in the AMA Guides. She is a graduate of Northwestern University Medical School, trained in internal medicine and occupational medicine at Cook County Hospital in Chicago, and received her degree in public health and epidemiology at Johns Hopkins. Dr. Cocchiarella has more than 25 years of experience practicing occupational and internal medicine and has established herself as a leader in the area of disability assessment. Following a career in academic and administrative medicine, where she more recently worked as the assistant medical director for the NYS Workers' Compensation Board, she has returned to a more clinical focus. She practices occupational, internal, and addiction medicine and is thankful and always ecstatic to come to beautiful sunny California.
That is very, very true.
We're so happy to always have her.
Thank you very much.